So let's start the recording. And so I hope everyone is able to see my screen, right? Okay, so this is our agenda for today's session. We'll take first 15 minutes to go over the introduction, guiding principles of design and purpose of this session, and we'll be going over the enterprise end-to-end workflow. Then I will pass on to Patricia, Ivana, and April, who will go over the provider piece first, and then we'll be going over the allied health workflow and the demo in Cerner. Then I believe nurses will join, and we can go over the nurse educator piece and medication as administration part, and then procedures and treatments demo. And then we can go over specimen collection in between clinic visit and message center and virtual health part. And then we'll be providing 15 minutes for additional question and discussion. And in the end, we'll go over the next steps after the session we'll be having. So quick housekeeping items, like please mute whenever you are not speaking, and please state your name so that we can record accurately the meeting notes and follow-up items. And feel free to add any non-urgent questions in the chat. And as you know, we are recording these sessions, and feel free if anybody has any objection on this. So on our subject matter expertise list, we have Dr. Connie Yang and Dr. Tiffany Wong, allergist, Dr. Kyla, and Dr. Clary, pediatrician. I think she is not available for this session. And Ingrid, Lindsay are nurse educators, and Mabel, Tan, and Maria and Okiana are from nursing. We have our CST team, ambulatory team, informatic leads, informatic specialist, PET team, provider adoption team, and medication management team. CST team will introduce themselves whenever they are going to present their part. And we have like Dr. Coney, and we know, so I guess whosoever is joining can introduce later on when we go over the, or if somebody has some questions, they can introduce themselves during that part.
Yeah.
So let's go.
Sue, I think Ingrid is on the line now. Yes. Hi, Ingrid.
Hi, Ingrid. Okay, yeah.
Hello. So yeah, we have clinic today, so we were just a little bit late getting here. Lindsay's still in clinic, so sorry about that.
Sounds good. Since we do have you as one of the nurse educator representative, if it's all right with everyone, we can get started with that. Would that be okay?
Sure. Yeah.
Okay, sounds good.
Okay, so we'll quickly go over through the guiding principles. So we are configuring for enterprise-wide, meaning we are configuring for all three organizations, and these four are our drivers for the what we must have. And first one is safety, meaning the changes that have patient safety implications. Second one is regulatory, which means the changes that are required to meet regulatory reporting requirements and international or national standards. And third one is financial, that would create efficiency without requiring significant operational cost implications. And last one is content, the changes to add content that currently doesn't exist and is required. So purpose of this session is to review the current workflow, what works, and identify any gaps if are present, and review the content that currently exists in the Cerner, validating what works as is, and if there are any changes required in the system, and we'll be validating the standards and processes that will configure the new system. So now I will pass over to Patricia to go over enterprise end-to-end workflow. Thanks.
Sorry, I think.
Oh, I'm so sorry. I was on mute. I was like, hi everyone. It's Patricia. I'll be facilitating the nursing pieces and some of the other slides here. So we'll start off with kind of reviewing the end-to-end workflow, kind of just really high level how a patient travels through your clinic. So from receiving referral, screening and triaging, those referrals are either accepted or rejected by the providers. Those referrals are either waitlisted, and if available, to schedule the appointment. Those appointments are confirmed with patient, and when patient is arrived for the day of their appointment, they are checked in and registered. So this is from 1 to 7. This is currently a design that we are tackling as an enterprise a flow enterprise decision for the entire respiratory division clinics. So, for example, Ingrid, this is something that we can go through and review with your team during the validation session for the rest of the clinicians to be able to view. But for this session today, we will be focusing from 8 to 14, which is the nursing pieces, the allied health piece, and the provider pieces for documentation in the system, and also medication administration as needed, procedures and treatments, specimen collection, and of course the follow-up and patient departure process. So starting with nursing assessment and documentation. So in our system, if nurses can see patients have arrived either physically or in the system using ambulatory organizer, the same assessments as you would do without an EHR. You check your orders, labs, complete intake forms, check and document vitals, head-to-toe assessment, complete your interventions and documentation. And in documentation will be clinic and task specific. Nurses will document typically via PowerForm, interactive view, or dynamic documentation. And I'll kind of go over that a little bit in these slides and demo. So just a little trajectory here. So nursing will review ambulatory organizer and power chart to review their schedule for the day to see which patients they're going to see. They can go ahead and click into that patient to see that patient's electronic outpatient chart to review any information. They are able to administer medication as needed, and also document, again, those assessment and intervention, either PowerForm, dynamic documentation, or in iView. So a little bit of how ambulatory organizer looks like. So the next couple slides are just going to be a little bit of some screenshots, and then I'll go straight into the demo. This might be familiar to you right now, knowing that you guys are using the system. So please just let me know if you need something more detailed or less detailed. So from the ambulatory organizer, you're going to select a resource group. So in the future, it would be something like BCH, Asthma resource group, for example. And that will pull all the appointments that are booked for that specific clinic. Or you can actually select your name in the list so that you'll only be able to view appointments that are scheduled for you. And this is kind of how, yeah.
Oh, hi, Patricia. Sorry. For the nurses, I don't think our asthma nurses have patients individually scheduled for them. Is that correct?
That's something that we can discuss and try to figure out. I think current state, you said that's not something that you guys are currently doing.
Correct.
Yeah. Future state, there is like an opportunity to do that. But if they are booked into if the appointment is booked and they're considered a resource for that appointment, if they go into ambulatory organizer and enter their name, it'll still pull that appointment because they were tagged as a resource for that appointment.
Okay, maybe we can circle back to that because you guys would know how the system's getting built out. I think current state is that we don't list the nurses as resources because who they see on any given day depends on the huddle in the morning.
Oh, I see. I understand. Okay. Okay.
Sorry, just to interrupt. We're listed only on sort of extra appointments where it's not the team clinic, because our clinic is a collaborative clinic, and so on days when we're not having team clinic, We often see kids on our own. So that's when our resource it's booked under us as a resource. And right now it's not our name. It's when the original Cerner was built, it was just, they put in RN1 and RN2.
Okay.
And so is that going to be changing?
We can mimic something like that the same way as well. I see that Jacob's on the line from our scheduling team, who can kind of maybe comment into that, or Peter just mentioned in the chat, so we can build out into the system as the generic resource currently what you have, nurse 1, nurse 2.
Yeah, essentially the scheduling folks, the people who work with the clerks, to fully understand kind of what's needed to build out the appointment types and the resources, people and otherwise in your clinic. They can either build them as specific staff members or as generic staff members, nurse 1, nurse 2. It depends on what will best meet the needs of your clinic as the design process unfolds.
Mm-hmm.
Yeah, just so you know, Ingrid, as we're designing this, I don't think it's going to change from what we have. So like on a given clinic day, it wouldn't be booked with you guys as a resource, but the when we're not in our collaborative clinics and you guys are seeing patients, you'll see your own patient list. Just to put whatever Patricia's saying in a bit of context there.
Right. Thanks. Okay.
Sounds good. Thank you.
It's just Brenda here. So our, like Jacob and Pamela, our scheduling team, I think does have a session booked with your clerks, and they go over all that detail and look at the resource groups and sort of mimic what you have in current state, and or if there's any new things that that are changing. So they can make it as generic as possible, or they can get really specific, and they'll work with the clerks to get all that information.
Sounds good. Thanks, Brenda. Nice to see you.
I know, you too.
Is my camera working, by the way? Because I don't see my that my video is working for some reason.
I have my video on. I don't see you either, though.
Okay, never mind.
So if it's all right, I'll just continue. So this is kind of like a view of the patient's outpatient chart. So I'll go through a little bit more in detail in the demo regarding these different components. And for nursing documentation, as I've previously mentioned, there's 3 types of kind of forms of documentation in the system nurses are able to utilize. The first one is dynamic documentation, and this kind of mimics how we document our progress notes. And it can come in 2 different types of kind of forms, whether it's an auto text, so something that we built out as pre-filled, something that we're currently investigating as we've received some of your current templates that you use for the asthma clinic, and also free text, which is just maybe you just want to quickly write a nursing narrative note, for example. Power forms, we do have something built out, such as the pediatric intake form that we can review to see if that will meet your needs or not, or if there's things that you like there or things that you might want to add, something we can take back. And also iView. So iView, to be able to document maybe a system assessment, whether you did a respiratory system assessment, vitals, or the PRAM. So a little screenshot of dynamic documentation. On the left, you can see this is kind of an auto text little note, and on the right is a free text note where it's empty and you're filling it out yourself. Power forms look a bit like this. They kind of look like almost equivalent to kind of like our flow sheets in a way, where there's different multiple tabs in the form that you would have to click through and document. Anything with a red star on it means that those are required. There's a required field that needs to be filled out in those components to be able to sign the form, and you are able to document on any section that pertains to your assessment. And a little bit of iView. So again, respiratory assessment, if you are going ahead and documenting that, such as the PRAM. Or we also have the respiratory education, which from the notes that I've seen that you've sent might not entirely fit for for your clinic, as it's a little bit more, your documentation is a little bit more detailed, but I just wanted to show you that there is something there for respiratory education. So I'm going to go ahead into the demonstration. Just going to quickly put my screen down here. Okay. Let me know if you can see the my screen here on PowerChart. Perfect. So when you log in first as a nurse, using your own username, usually the screen is blank. Your main page, your landing page, is actually called Ambulatory Organizer, and which I'm just going to click into it. And usually it'll be blank unless you've already logged in and chose your resource group. So for example, here I've chosen the LGH Peds Asthma Resource Group just for the demonstration purpose today. And to change your resource, or for example, want to add more, you can just go ahead and search for the location and go ahead and select that resource group that you would like to use, for example. So as you can see here, we got our test patient here, Julia, and for ambulatory organizer, time is the very first in the left corner here, where it also indicates the resources that the patient is booked for, the duration of that appointment, that patient's name, and if I hover over that patient, I'm actually able to get a bit more information. There's no phone number added here, but if the phone number was actually entered during registration, you'd be able to see that as well here. And the details would be the type of appointment. So as you can see, we got the Peds Asthma New, so this is considered a new patient, and we also have at the bottom here, Peds Asthma Follow-up. With this one, you can see that there's a comment, for example, Zoom. So if you indicated in your that some appointments are virtual, and the nurse are aware, the clerks are aware, their clerks are able to put a little comment in their special instruction that will populate into your ambulatory organizer, just as a good prompt. And we go into now the status column, and as you can see here, Julia, the first blue line here is checked in. So this means that this patient is here at the clinic and is ready to be seen, versus at the one at the bottom where it's confirmed, meaning that that patient probably hasn't arrived yet and checked in into the clinic. The last column is notes. So you can tell that why the patient is here for their visit is a little blurb here. And also you can see that there's a little plus sign to create notes as needed. If, for example, I'm a clerk and I called the patient and I wanted to just write a note that patient confirmed for appointment, for example, so that other clinicians are able to view that. So these little sticky notes are not a legal part of the chart, so they don't save anywhere. It's just mainly for a front-facing kind of communication piece. So I'm going to go ahead and enter the patient's chart by clicking on it. And I'm going to set my relationship as the nurse. And I will land in the menu from the menu, the ambulatory workflow, in the AM workflow tab. So this is your main kind of workspace. So we use these tabs as kind of like workflow. We call them workflow tabs, where you're able to go through different components to be able to review the patient's chart. So for example, the first component is chief of complaint or reason for visit. You're able to document little pieces here as needed. Team communication discoverable. So if there's any like quick notes that you need to note here, such that it will prompt other clinicians to review, you can go ahead and do that here too. But this part of the chart is again kind of like a sticky note. It doesn't. It's not a legal part of the chart. It doesn't save into the actual documentation. Patient information. So if you need kind of contact information, emergency contact, that it would be here. The patient's parents' number, for example. You got the visit tab. So the visit tab will record kind of the patient's appointments. So as you can see, we have the appointment here at the Peds Asthma for a follow-up and the pre-outpatient. Okay. History.
Sorry, can I just ask a quick question? That patient in the visit tab, is that keeping like the history of all the visits?
Yeah, exactly. So if the patient had a different appointment in a different location, you'd be able to see it here. So as you can see, I just have like this is just a prototype right now, but BCH asthma, for example, I can see that previously the patient was there had an appointment there on March 22nd.
Yeah, sounds good.
Yeah, which is kind of nice if you want to also maybe schedule an appointment in the same time of a different appointment, for example. History, so procedure history, social history, family history, pregnancy history. So these are all kind of where the patient histories that were recorded would flow into. Active issues, so this will be where you would find maybe asthma as a chronic problem or hypothyroidism, something like that, that would be documented by the providers. Documentation. So again, this is where you would be able to view all the documentation that was created by every clinician. Home medications. So you'll be able to review any home medications that was documented for this patient. So they're kind of their medication history.
Sorry, Pat, it's just Brenda here. Is that a shared responsibility amongst the physicians as well as the NP and nurses as to who documents home medications?
Yes, I think we both review it. Are you talking in terms of like med rec or?
Well, it's a little bit of both and within Cerner. So there's like that BPMH part, which certain roles can perform, but the actual reconciliation is a provider specific functionality. So, Ingrid and her team can go in and document, through med history, what all medications they are taking at home.
Right.
And then the reconciliation part is a provider functionality.
Right.
So this is kind of shared. It's sort of whoever is seeing the patient first, or.
Yeah, I think that's fair to say, although, yes. Yes.
Okay, thank you.
So if it is going to be a shared responsibility between the nurse educators, the NP, and the providers, so I'll just kind of show you, I'm kind of just showing you how that as a nurse you would be able to document. So what I did was I just clicked on the med history status here, and this opened up the document medication history tab. And to document the type of medications, you would just click add, search for the medication that best fits what the patient has told you they're taking. And then you can double check in the details at the bottom on the details to ensure that it matches. For example, I can change this to 2 puffs regarding what the patient during the interview or the parents have told you about the medication. You can also document the compliance. So if maybe they're not taking it as prescribed, you can also document a little comment about it. And so I can go ahead and document that history. And as you can see here, we got a check mark status, and that tells me that the patient's med history has been completed, and I can see what was actually documented.
Yeah, and Pat, what we'll do is there's a somewhat of an integration with PharmaNet.
Yes.
Unfortunately, in our bill domain, there's only certain patients that have that. So we'll show you what that looks like in during our validation, but there's also an easier way, you know, that the piece of paper from Pharmanet will be available electronically to you all as well.
Yes, thank you for that. So we can go ahead and preview that the next time we meet. So the next tab, we have the vitals and measurements. So if any vitals were documented, it would flow here. Labs, diagnostic. So if a patient had any labs or diagnostic investigation, again, it would flow here. And outstanding orders, if there are any outstanding orders. Forms and iView. So again, this is kind of a quick link for you to be able to maybe document the pediatric care intake or transport ticket, for example, or if you're doing a blood glucose point of care, which we understand no point of care testing is done in the clinic, so might not be relevant for you. And we have the new order entry component where you are able to enter orders, for example, the follow-up clinic order as needed, and any planned power plans for this patient. So power plans are kind of just sets of orders that might be ordered for a patient that you can review. Advanced care planning and goals of care if it is documented, and any allergies. So for allergies, for example, I would like to add, I did my interview with the patient and I'd like to document an allergy. I can go ahead and do that by going through here and searching for the allergy. And then I'll get a little window on the right side of the screen where I'm able to document a little bit more about that allergy. Yeah. Go ahead and do that. And I'm going to go click save.
So I just had a question about tests that are done. The one that we sometimes do or often do is skin prick testing. Where does, Connie, do you know where that comes into play here?
Do you mean the allergy skin testing?
Yeah.
Right. So that's currently something we're investigating in regards to how we're translating that in the system. That we actually have a few other questions a little bit later on the slide about that, if maybe that's okay to discuss that during that time.
Sure.
Okay, thank you. So that's a little bit of the outpatient chart, and as you can see here at the bottom, you have some quick links to take you to your type of documentation. So I'll start off with the dynamic documentation. So for example, I want to document a nursing narrative note. So as you can see here, this is a free text note. I can just document a narrative note as needed, you know, to complete my assessment and intervention documentation. But again, we did receive your templates that you are using in the clinics with your with kind of like a set thing already. And so we wanted to show you how an auto text looks like. So as you can see, I start off by typing comma and peds as an example. I'm going to choose the peds asthma follow-up, and I'm going to just double click on that. That auto text will pull up kind of a pre-completed sections that will populate if there are things documented in the chart. For example, I documented the home medication. It pulled it into that documentation. And also, if there was any investigation / PFTs, it would fall here. And at the bottom, we got the impression and plan, where I can also document, you know, my investigation and plan of care for this patient. So not exactly the same as what your current template, but we're trying to see if we can provide you something similar to it. Any questions or concerns about this, Ingrid?
Well, it's going to be a process because this is nothing like what our template is like right now. So I'll just follow along and wait and see what you guys have to say and how we.
Sounds good.
Work through it all. Yeah.
Yeah. Go. So, Ingrid, and I know Connie is aware, you know, like working off those, what we call M pages, like Patricia, if you go back is sort of the positive sort of the positive aspects of working off of this versus just going directly into sort of like a free text note is this information will flow and sort of cross encounters and be available up front for other clinicians, right? So like if the allergies are captured up here, then when Connie and her team need to go do something, the allergies will also flow into their notes versus having it sort of embedded within notes. So that's sort of one of the positive and sort of reasons that we do encourage the use of these M pages. It crosses encounters. So, you know, like if the patient was seen in another clinic and they, you know, put in all the histories on this versus just a note, when they come to your clinic, you're able to go to histories and it'll be all populated for you.
Yeah, that totally makes sense. I think the nursing role here is, you know, is very specific. So again, let's just go through it and see. Can you just clarify what M pages are? What do you mean by M pages?
Oh, sorry, our Millennium pages. So these workflow pages. These are all individual tabs. So we refer them to as their M page workflow summary. It's Cerner talk.
Yes.
Okay. Yeah, sorry about that. Yeah, so again, like the different tabs, so your main tab, main M page would be the workflow, and then you also have like the summary if you just want a quick overview of the patient that you can do. Also, there's like demographics if you just need maybe more of that kind of information, and also a quick order if you need to enter any orders.
Can I ask two questions? So the quick orders page for the nurses, are they creating their own quick orders page, or they're going to have the same as whatever we're creating for the respiratory physicians?
No, they wouldn't be creating any, not the same way that they're doing with your team, Dr. Yang.
Yep.
Yeah.
I believe it's preset for nursing.
Oh, like generic?
Yeah, very generic.
Yeah. It's generic.
Yeah, so it's very like, you know, if you can see here for an example of this is all of those sort of nurse initiated activities and things that nurses can sort of place independently of providers.
Okay.
Yes.
Just so you know, Ingrid, you'll probably never use this page, just because none of this stuff really applies to really what we do in asthma. Like even though I don't even see like, because one way this might be helpful in ambulatory is if there was like a quick orders medication. So that like instead of searching for all of the asthma medications on the physician page, we have our common medications, but that's not here because they can't order them.
Yes. Yeah.
Right. So they can document them, but they have to go through the long search way.
Yeah. So this quick orders, a lot of it is more, it's more geared a lot, I think, towards your inpatient nurses or your ED nurses who sort of initiate like protocols or anything like that, or like, you know, if they're doing lab levels on a patient, you know, after third dose of antibiotics that they have to place those orders, that's kind of what gets built out. So it's primarily more focused from an inpatient perspective.
Gotcha. And then the second question is, given that the nurses have the ability to do free text notes, can they actually just copy and paste? Like, so I think workflow now is they just copy and paste a Word document into there. That will exist in the new system?
Yeah, I think that you can still copy and paste from a Word document. Is that correct?
This is Peter. I've tested it. You can.
Okay.
It's possible.
And then I think the other question that sort of came up when I was chatting with Ingrid and Lindsay is part of the reason they do that is because there's no sort of spell check or any other functionality within our current CST. Is that different in the new CST system?
I believe we have spell check that is embedded within our Cerner system. Fraser, can you correct me?
Yes,
I'll double check.
Yeah, I believe like you can see right here. Yeah,
I'm kind of doing it right now. You can see there is spell check. Inspiration.
Out of curiosity, why is it spell checking stuff that's actually right?
Yeah, I'm not sure.
Fair. Okay, so probably it's possible, but Word probably has better functionality. Okay, sounds good.
Okay, so going back to the note, I'm going to go ahead and sign and submit once I'm happy. The only caveat to any free text note is, as you can see, the title automatically defaults to free text note. So best thing to do is always to go ahead and change this to whatever title fits your clinic and your workflow. I'm just going to click on the documentation tab here so that you can go ahead and see that once I've signed it, it becomes a legal part of the chart that is with the final report statement at the top of the note that is going to be viewable by any clinician.
Can I ask another question about this while you're on the documents page? Because
Sure.
I think part of the issue we have with CST now is like everything just shows up in this giant like 50-page list. Is there a sort of, and especially given that all the nurses across the institution, I'm guessing the subject or the sort of note type is nursing narrative note, is that the only way to search through this, or how does Ingrid find her last 10 nursing notes quickly?
Right. So we do have like a filter, as you can see, the little 3 dots here. It might be a little bit much in terms of having to go ahead and filter, but I can select a document author. So if I'm specifically looking for Ingrid's documentation, I would search for Ingrid's last name and first name and go ahead and click apply so that I can filter through multiple documentation that's been charted on the patient to see what Ingrid has maybe documented from a provider perspective or Ingrid's perspective, or you can specifically look for a specific document type. For example, I wanted to just find OT or PT's notes, for example.
Or can you go into nursing notes, maybe just a bit more relevant for
sorry. Yeah. So nursing documentation, I can go ahead and select apply to go ahead and see that.
But what are the subcategories of nursing documentation, or does that literally just pull up everything this kid's had in the hospital documented by nurses?
I believe, let me just double check. So yeah, it would be the nursing procedure or nursing narrative. So if it is nursing narrative note, so it would be any nursing narrative note that's documented as that type by any nurses.
Yeah,
and then filter to pull it up by clinic or encounter type as well. So the encounter type associated with the clinic.
Yeah,
I was just going to say that.
So Peter, that was a bit muffled. We can pull it up by area, like by asthma.
Ingrid, what we'll show you is what Peter was saying is on those sort of big sort of summary pages, there's ways to filter documentations because absolutely you're correct. You know, a patient could have 500 different notes. So you can group by encounter. So you can group by encounter and that would sort of just streamline it into buckets and you would see like, you know, asthma clinic encounter and all the documentation associated with it. Mm-hmm. This gets you a really granular, like if you're not even happy with that and you want to kind of create your own, you could pull in so much this way.
Right.
Okay, that'll be helpful.
Yeah, and that's a piece that we can work with you during the adoption education phase, and that would just kind of help optimize your the effectiveness of the workflow for you and your colleagues. So the next type of documentation, again, is the Power Form. So to access Power Forms, again, there was 2 ways that the first way I showed was going through the AMP Workflow tab and going into Forms, iView, and clicking on the downward button, and clicking on Ambulatory Pediatric Care Intake Power Form, and that will directly open that Power Form up, where you're able to document the summary for the patient, vital sign, height and weight, allergies and meds. So kind of the same thing that we just did in the M-Page workflow. Any problems, histories, ID screening, so infectious disease screening. I'm actually just gonna quickly document on this so we'd have a little bit more. And immunization, nutrition, breastfeeding formula, and another nutrition.
Sorry, so just to back up a little bit and clarify, this page, is this done every visit, or are we responsible to like Like, when is this done?
Ingrid, that would sort of be your policies as to sort of when you do this for your clinic.
Yeah, so Ingrid, for our clinic, this isn't usually a nursing role. I think that's why I was asking before about the patient care aides. So for example, and also the RTs, like usually if in an ideal world, a patient care aide does a full set of height, weight, and vitals. Is that sort of a possible thing in this system?
Yeah, they have, there is healthcare aid positions that they have the functionality to measure things like weight, vital signs. I have to take a look, but we do have that functionality for our live sites. And I just don't know which clinics have healthcare aides. I'm not sure if you have one specifically, but if you do get one, they definitely do have this capability. They do not have the capability of doing histories, medications, but your basic vital signs and weight, they do.
Yeah, so Ingrid, for our clinics, I would suspect the workflow is not going to change. We'll probably have to figure out who documents medication. And my guess is part of that is we need to see how well stuff flows in from PharmaNet and how much time this is going to take. Right. Yeah, because I think that's what we learned the first time when we did this pilot ambulatory business.
Sounds good. So knowing based on your feedback and that, this is something that would not particularly apply to your clinic, this ambulatory pediatric care intake form for asthma clinic.
Correct.
Is that what I'm hearing? Okay, yep. Thank you.
Sorry, I just had a question just about the last comment, and I know we have, I'm not sure if Justin's still on the line. Just with regards to BPMH and MedRec, I believe the sites decide which clinics are to perform them. So depending on what their decision is, we will show you that functionality in our another demo, and we will always show you sort of how to do it in the system, but the site sort of directs which clinics are responsible for doing that.
So our clinics are, we're just having this discussion now, so we will be responsible for sort of best medication and med rec. How that actually happens is to be decided. So we're going to be doing it on paper now, and I think they're waiting to see what this CST functionality is to see if it makes sense or not to do it on the system.
So, and Connie, I'll just say, the only time we would do vital signs medication orders is when a kid arrives sick, which is what has happened in past years. Of course, not this past year because nobody's been sick, but there's been quite often where a child has arrived and we're doing tram scores, we're doing Ventolin before we send them off to emergency. So then we'll cross that bridge, I guess, when we get there. That stage.
Yeah, so if that's sort of the case, then I guess Brenda or Patricia, I guess that whole power form would be one way to do it. Can she just click into vital signs and measurements and just do a quick documentation?
Yes, and I can show that right now. So for those cases where that's more of your 10%, 5% of your that could occur, those iView would probably be the best to document those type of assessments. So just from the menu, it's called Interactive View NINO, or iView for short. And you can see here in the pediatric quick view, just please ignore some other tabs here, but as a pediatric nurse, you wouldn't see the adult tabs here later on. But in the pediatric view, you can see that the documentation of vital signs that I documented in a power form flowed here, but I can also go ahead and click into this row where it's telling me the actual time currently, where I'm actually able to document the vital sign that I completed for that patient. So again, for those situations where that you just described, Ingrid. And I would go ahead and click the green check mark, which is an icon for signing, and once it turns black, that's a legal part of the chart.
And since we're in this section, can you just show us what that respiratory education something or other is?
Of course. Yeah. So the other pieces is one of the forms that we've received back from you guys had the vital sign and also the PRAM score. So to be able to find a PRAM score, you would have to go into the pediatric system assessment, which is basically a head-to-toe assessment documentation for nursing. And by clicking on the respiratory tab here, I can go ahead and find the PRAM score here. Or maybe it's just not on. So if you can't find it, we just have to activate it.
Oh, sorry. And it wasn't the PRAM score. There was some kind of education, respiratory education.
Right.
Connie, what we're doing now is we actually had a session and just looking at all those education flow sheets that everyone uses to sort of find out the best way to capture it. Like, will that remain on paper? Some are really updated and great. Others are very outdated. And some require patient signatures, some don't. So it becomes quite tricky to try to sort of incorporate that into Cerner when there's such varying degrees, and then it could possibly even pose more confusion as to like which ones are on paper, which ones are built in the system. Here we have a very, very basic one, but it does not follow that. I think it's like a 2-page flow sheet that you guys have. And so we're just sort of in the middle of discussing like what's the best way to handle, to sort of look at this. This is very basic asthma education. It doesn't get as detailed.
About the education checklist that's used in the inpatient unit? That's one page.
Yeah, they said they had the both. I think I'd have to pull it up, but it's the one I think that also is used. I'm not sure. Did Child Health get involved with that one?
Nope.
No.
Okay. So yeah, so we focused on the inpatient perspective for that, but we do need to sort of figure out what's the best way to incorporate those within, knowing that there's, variations amongst sort of education flow sheets, and some are outdated, some need signatures, and just to kind of make it more standard as to how we can capture that. Does that stay on paper and get scanned into the system after? This is just very basic asthma education that we have here. Doesn't get as granular as the ones that you guys have.
Yes. So for kind of each section here, the 4 kind of sections that you're able to document is either verbalized understanding, demonstrate it, needs further teaching, needs practice supervision. So again, might not really fit the detailed documentation that you do for the clinic.
Yeah, like maybe I can just clarify, because I think maybe we're talking about lots of different kinds of documents. So there's an inpatient checklist that is like the education, which is fairly sort of basic, that all of the nurses on the ward should be able to do. And then there's an actual asthma clinic flow sheet. There's a physician one and a nurse one that is much more for our clinic. It doesn't go into any of this stuff. It's just like, what did we do with the patient? What are the quick things we need to know about the patient? And that flow sheet, is that something you guys are going to talk about during this session or no?
So when I took a look at that flow sheet for the nursing piece, Dr. Yang, I believe it had like these kind of information, right? The triggers, oral IV, steroids, kind of home environment pieces. Is that correct?
Ingrid, do you know what's on the nursing flow sheet?
Are we talking about our clinic documentation and our templates that we use?
So we had like 4 different documents that we received for nursing. So the first one was your nursing clinic flow sheet, which is kind of mimics this auto text that had information about triggers, like the visits, oral IV, steroids, impressions, and plan.
Sorry, we don't have anything like that with oral IV antibiotics. We have a clinic flow sheet that lists, lots of the education that we've done, the plan, and then some psychosocial information. So I'm not sure if we're talking about the same document, because this doesn't sound familiar at all.
Okay. Ingrid, is it possible for you to send us what you use, or Connie, and then we can do another cross-reference? Because that's sort of we received, I think, what Patricia was saying was 4. So if there's anything that we're missing, this will be the time to sort of maybe just send that to us, and we can see what the equivalent will be in CST Cerner.
Yeah, so just to clarify, those all got sent with the initial sending of forms, and then what we resent were the actual clinic letter templates.
Yes, we got
So
There is
the
3.
4 that you guys are probably, or the 3 or 4 that you guys are talking about, I'm guessing those are actually clinic letter templates. Is that right? Or can you share a screen and show us what you're talking about?
Sure, I could do that. Let me just quickly. So for nursing forms, this is what we receive. Sorry, those are just my notes, please ignore. So you have your severe asthma education nursing flow sheet. I think this is what you were talking about as your quick view.
Yeah.
So in terms of my cross analysis of where these kind of information lives, so your initial new diagnoses, asthma pathophysiology, that would be your active. That would be found in the active diagnoses of the ambulatory component page. Maybe if I could do like a side by side. Active issues. So that would be where the nurse would be able to view that if that was again, the diagnosis is documented by the provider. Follow-up asthma control, whether I'm thinking this is maybe like an order. If it's a follow-up appointment, then that would be a follow-up order. Your triggers review, avoidance list, and flu vaccine. That would be either in the medication history, or we have our immunization tab here to review immunization, for example.
I think that the purpose of that flow sheet, if I can just interject, is not to document orders that were done, but we're having a discussion and consultation and counseling with the patient as to their specific diagnosis, where they're at with their asthma control. So we're doing an asthma control assessment, and then we're reviewing all this from an educational and strategic management plan.
Okay.
For the family. So if that helps to clarify.
Okay, I see.
This is a quick access that we keep in our Cardex file, so that if a patient phones, we can quickly look up when their last visit was and who saw them, kind of thing. But the actual formal documentation that gets put into their power chart is done on our templates that are titled new visit, follow-up visit, and I think there was a pandemic version, and I don't know.
Right, is it this one? Ingrid?
Yeah.
Right, so this is the one we are investigating, like in regards to creating this kind of like for like in a way in the system. So build it out as a auto text, but again, you also have the opportunity to copy and paste it, as we've discussed already, from Word, if you would like. Where you would still have to do the fill in the blanks, right? So that's something that we will, kind of how you saw me do the comma, if you put comma, ped asthma educator, this whole thing would potentially could pop up with the blanks, and you can just go ahead and change the blanks as needed, as what you're currently doing.
So I think, and this is why this is simply a template, because every educator is quite, different in how they document and how they use this template, and not all of the template applies to each patient, and so we delete stuff as we don't need it, we add stuff if more detail is needed, and it's just the purpose of developing this was really so that new staff coming in, new nursing educators would have some, have a guide to their charting. And I have a suspicion that we're going to probably continue to use our Word documents like these templates, and then copy and paste them into a free text note for now.
Okay, so you're thinking like keeping the free text and keeping this as a Word file for you guys to kind of copy and paste for now.
Yeah, and keep it in Cerner as a document, so that if a new nurse comes in, she can use it if she, he or she.
Okay, yeah. So Ingrid, the ultimate goal, right? It's Brenda here. If we do, investigate this a little bit more and build an auto text, is to have every, nurse educator do the same standards and documentation, right? So there's no variation in practice. Like you base it off of sort of like best practice and standards of care for the patient population.
Oh, absolutely, yeah. So it's not that, you know, any nurse can come in and do the role. We do have, you know, we're certified asthma educators. It's very evidence-based and according to our nursing scope of practice. So.
Yeah. And for the other one, sorry, you mentioned Cardex, so that does not become part of the health record. This is just kind of like a worksheet for you guys.
It is, and what we do with that when the patient is discharged is we send it to health records currently. And I think our current secretary started scanning them in if the patient is discharged from clinic.
So do you know, does this get scanned into the system? Like I'm just looking at it and I'm just curious if it's like got the formal sort of forms approval.
No.
It's a worksheet. Right?
Worksheet. Okay, thank you.
Great.
Although it's a worksheet that goes down into health records when we're done with it. So technically, I would assume if we're sending it to health records, it's part of the official patient chart.
Yeah, I'm curious. We'll have to follow up to see, because this happens from other clinics. Actually, what does health records do with it?
Right.
Do they actually
do anything with it? Yeah.
Do they do anything? Do they remove it and actually shred it? So I'm just curious as to, we'll have to follow up.
Right. I have found them in a patient record, not a paper record, but in Cerner. So obviously they are being sort of scanned in.
Okay, so they are right now. So you'll find it sometimes. Okay, thanks.
Oh.
Sounds good. Yeah. So some of these kind of pieces in your notes are kind of scattered throughout the patient's chart to find. I just want to clarify, was I hearing that this is for this type of your flow sheet, this is something you'd like to keep kind of together, like with the exact same information?
Not quite sure about your question, but yes, we're going to keep using this as our clinic Cardex.
Gotcha. Oh, okay, as your Cardex. Okay, sounds good. So we just have to then, as our follow-up, is to figure out if this is going to be scanned into the system. Is that correct, Brenda? Or it just stays on, it'll just stay on their paper, into their Cardex?
Yeah, like from the Cardex point of view, if you guys want to maintain this, there's nothing
stopping
you. It's just it's sometimes double documentation because you can find the information electronically, and then we'd have to follow up to see like what current health records, what does C&W health records do with these when they come to you. And if you do want that to be captured in the chart, then it would most likely have to go through the whole forms approval process in future states. So it's something just for us to take away and sort of figure out if the forms approval process for C&W and the project, and because every form that we want either uploaded into the system or scanned needs to have a stamp of approval.
Can I ask, Brenda, because I think there's lots of stuff, whether you call it a form or a letter. If Ingrid wrote a letter and then sent that down to health records, what's the difference between a form and a letter?
What I always say with that is it just depends on what becomes part of the electronic health record. Mm-hmm. Right? And so if your, letters that you send off to patients do become, and they have that stamp of approval, either way, a form or a letter, and anyone who's on the line can correct me if I'm wrong, a form or a letter, if it's a stamp of approval to be the electronic health record, would get scanned into the system. But if they don't have approval, that's sort of that gray area right now.
So I can add to that as well. Essentially, to become part of a medical record, it would need to have the patient label as part of it and be kind of one of the approved documents that would go into the permanent medical record. For it to be for sure approved as one of those documents, typically in a perfect world, it would have gone through the organization's forms approval process. As it onboards the CST Cerner, it will be loaded into the CST forms library. When it's needed and used clinically and printed out from the CST paper forms library, the patient label will actually auto-populate onto that form and just be part of the printed form. So the form will actually contain the patient's name and all their demographic info, all the stuff that would typically be part of a patient label. For any documents that you want to send to health records to become part of the permanent medical record, if it's not a form that's printed from FormFast with the patient label already on it, if you want it to become part of the permanent medical record, you would need to attach a printed patient form label with the patient's name and identifiers onto that, what is called an external document, a document that's not recognized as a formal medical record document otherwise. And if you need to do any other, sometimes the second label is added to categorize what type of document as well as which patient it should be attached to for that external document. So a letter, because it's not coming from the paper directory or forms directory from FormFast, you would need to for sure attach the label onto it if you want it to become scanned as part of the permanent medical record. And then some of the additional pieces is sometimes if people some people get kind of form happy or label happy, and they kind of put labels on everything. So if it's very clear that something should not become part of the permanent medical record, even if it has someone's put a label on it, health records may not record it or scan it into the permanent medical record with the goal to kind of keep the record at a reasonable size and not kind of put anything and everything into the permanent medical record.
And is there some like overarching list that we would know what's part of the official list and what's just we're gonna send down and gets thrown out?
That could be looked into in more detail. I think as part of learning the clinic workflow and part of moving through design to validation and then preparing for adoption, and my previous experience with other clinic design is to get a more detailed understanding of the type of document that you produce and what, if it's not going to be documented within CST Cerner, what will be sent down to health records and what the workflows around that are going to be, especially if there's documents that it's a written letter that does need to become part of the medical record that will not be created within CST Cerner itself.
So my guess, Ingrid, I don't know if anybody else wants to jump in, like this form will probably not end up, because a lot of it is sort of what's in the health records chart, but scattered out into 20 different places, making it not usable for you guys in a quick and fast way. My guess is we will keep this stuff locally and figure out how to deal with it. But yeah, kind of like we do now.
Yeah, sounds good. I mean, there's been times, patient phones and we grab their cardex and have everything at our fingertips rather than waiting for PowerChart to power up.
Yeah, and just to clarify, you will be asked for all of your clinic's forms that you regularly use, and if they meet the criteria, they'll be created in FormFast, and that's where the barcoded forms will print out of with that patient identifier information directly on the form. So I'm sure you've been asked to provide your
Yeah, so we've given all these forms. At what point will we know if it's part of that list or not, I guess is what I'm asking.
A little bit later in design, I'd say.
Okay.
Yeah, what I think often happens is kind of one of the validation steps, not necessarily, but sounds like it might be helpful in this clinic, is to kind of just present all for documentation that will be done outside of electronic charting, outside of CST Cerner, to just kind of have a list of those forms and make sure that it's complete and make sure that everyone is in the know about kind of how they're going to be used and which ones will be sent to health records to become part of the permanent medical record. That would be like a validation piece to make sure that everyone understands that the workflow and the build supports all of that for your clinic.
Yeah, and so Connie, I know that Excel spreadsheet that you sent on, our HIM department was sort of going through the hundreds and hundreds that they've received, and that's what they're doing right now. So we should know hopefully by the validation session, and as Peter was saying, like we'll have the list of all those that have been approved to be uploaded into FormFast.
Okay, sounds good.
Sounds good. So thank you, everyone. So just to summarize just the nursing pieces, for this current form, it's going to stay on paper to be used as your cardex. We're going to investigate if this needs the scanning kind of workflow for this on our end. And for your actual note pieces, we will try to produce an auto text to mimic the 3 types of notes that you've provided us. And if that doesn't work out and that's not to your needs, then again, there's still the option of being able to copy and paste this into a free text note. Is that what I heard kind of from our SMEs?
Yeah, I think that's pretty much it. Like Ingrid, I think looking at this, really the workflow is not changing much, and you guys sort of know how Cerner works. Like this isn't that different than the system we have. There's a few extra things like this ambulatory workflow, but to be honest, I'm not sure unless we figure out that you guys are going to start documenting medications that anything's going to change.
Yeah,
Right.
It looks very similar to what we do now, and just a bit of a new look. Yeah.
Exactly.
Sounds good. Perfect. So we do have like 2 follow-up questions, and then I'm going to hand it over to Peter just for a quick allied health screening questions. So Ingrid, do you ever collect specimen during a clinic visit? We know that some sputum collections are collected, but is it collected by you as the nurse educator? Or it's mostly providers or RTs?
Very rarely.
Okay, rarely, but it does occur.
Oh, yeah. Like MRSA swab. Yeah.
Yes.
Yeah, I guess the question we have is because some of the worksheets that we got back, the information, it just said like sputum collections are done, but it didn't really specify which clinic. Like from the asthma clinic, do you guys collect any specimens, like lab specimens or anything that you do during their visit for asthma?
I'm going to say no.
Okay, so no specimen collection in the asthma clinic.
I think as Lindsay mentioned, rarely we collect like swabs for MRSA if we're trying to get kids de-isolated. That's probably the extent of it. And then when we, like as physicians, we'll sometimes collect sputum samples, but it's not usually the nurses that do that.
Okay, thank you for clarifying that. Do other providers and or clinicians refer to you for a consult? So something that we noted was that the nurse educator sees patients in the ICU. Are you able to describe this process to us in a little bit more detail and how that kind of looks?
Yeah, sure. We have either CTU or an ICU physician will phone us and ask if we can see a patient while they're in the inpatient unit. And they should, it's done in 2 ways. Sometimes a phone call, and sometimes they phone a secretary, and sometimes it's actually a written referral form. Or they just walk into our office. Yeah.
Right, and this is specifically just for the nurse educator, and then are you going, is this during clinic time or whenever?
Yes, so it's on one of our either clinic days or non-clinic days, and yeah.
Sounds good. And just to kind of elaborate on a comment you made earlier, Ingrid, in terms of that you nurse educators in the asthma clinics sometimes do have their own schedule. Are these appointments your follow-up phone calls with the patients that you're providing?
Either phone, virtual health, or in person.
Okay. And this is just a follow-up with the nurse educator specifically, that appointment. Okay. And only for asthma patients.
That's right. That's all we see.
Okay. Thank you so much for clarifying that. I'm going to go ahead and move on to our allied health piece. Some questions we have. So again, allied health workflow is kind of similar. They're able to see a patient arrive or is seen by the nurse, either physically or in the system, an ambulatory organizer. And their documentation, again, is clinic and task specific. Typically, they document either PowerForm, iView, or dynamic documentation. Very similar to nursing. Of course, content is different. So I'll hand over it to Peter for a bit of some follow-up questions.
Can I just clarify, who are you guys talking about is allied health in our clinic?
Physical.
I was going to say, I don't think anyone gets consulted for your particular clinic, do they?
No.
So that's basically the main piece we want to ask. If some clinics will have allied health staffed into them, either part-time or full-time. Other clinics don't have regular staffing of allied professions, like OT, PT, social work, dietitian, for example. However, if there is a patient need, there might be a mechanism within the department where they can have that profession come and do an assessment by exception. So really, this is just a kind of a screening question or slide or placeholder to see if, even though that doesn't appear that there's any allied professions who are staffed into your clinic, if any of them occasionally get asked and will see a patient by exception or on a consultative type of basis within this clinic.
Social work. Social work, yeah.
And would you be able to kind of guesstimate the frequency of how often they're asked to see a patient?
Oh, well, we're in conversation a few days a week, but when they actually come to see a patient, or is this also we're asking them to follow up with the family once they're home, or?
I would say any care-based discussions or work that they're doing with the patient. So it could be talking to you about a patient, like kind of direct care related. If they're calling the family, I would consider that clinical care.
Yeah, a few times a week. Lindsay and I both agree.
And assuming that they're not staffed within the clinic, where are they elsewhere working, and how are they pulled into this clinic's work?
Well, they work. What do you mean, where do they work? They work for the social work department, and Connie, as I understand it, we have an assigned social worker. His name is Brandon, and that's who we call when we need help. And then sometimes they come to the in-person visit, and sometimes we do a collaborative phone call with the family, and sometimes it's just the social worker that's following up on an issue.
And do you know where else Brandon works? Does he work in inpatient or other?
Yeah, Brandon is like the ambulatory clinic's generic social worker. So he works in lots of different clinics. Can I just clarify with Ingrid, do you guys always fill in a social work referral form, or do you guys just call him about patients?
No, we tend to call first and then fill out the form. We always fill out a social work consult form.
Yeah, so site-wide for clinics, like the 90 clinics that don't have a social worker, we're supposed to follow a process that we use the standard social work referral form. It's just that Brendan is the social worker that tends to work at this clinic. But if he's away, it's going to be some other random social worker that's filling his space that day. So the workflow...
And what's Brendan's last name?
Burke.
U-R-K-E-S or K-E-S?
B-U-R-K-E with an E on the end.
And then the referral form for social work, was that included in the documents for this clinic?
It's on EPOP.
Oh, sorry.
Sorry, Ingrid.
That's okay. One more time, please.
It's on EPOPs.
EPOP.
It's a standard across the site form.
Is that an intranet or network system?
I'll send a link in the chat box.
Perfect. Thank you. And then does he see patients via scheduled appointments as well as one-to-one, as well as joint appointments with other clinicians in this clinic, it sounds like?
That's right.
Okay. You may or may not be familiar. Do you know what his documentation typically looks like when he does document his assessments or interventions within this clinic? Is it kind of free text charting or a dynamic document note?
Well, I don't know what a dynamic.
It's free text documentation.
It's like a free text note. It's like a free text note or a narrative, which then goes into PowerChart.
Okay, so I think that's probably what I need for now. I will connect with both Brandon, and I will also link him with Stephen Longstaff. I'll put his name in the chat just for everyone's reference. Within our CST Allied Informatics team, there's a couple of us, and we basically have split all the allied professions, and each of us are kind of leads for different professions. So my colleague Stephen Longstaff is the current design lead within the project for social workers. So I'll make sure that they're connected and that whatever Brandon needs to do is work in this clinic from a clinical documentation perspective. So that'll have the tools he'll need for his work. And then how he's scheduled for appointments and how he's kind of pulled into work in this clinic in terms of referral or basically scheduling pieces, that would all be looked at through the upcoming design work for this clinic as well.
Yeah, and just to clarify, like this isn't specific to our clinic. Like this social work piece, I'm sure if you talk to Luana, because when I've talked to sort of Sarah, our other social worker, they have standard documentation within social work. So this is not a clinic specific thing.
Yes. So one thing you may notice, especially at the outset when we're kind of in the requirements gathering phase, is as patients often experience in the hospital, and one of the things we're trying to prevent is with CST is that duplication of questions and information gathering. So at this phase in the process, requirements gathering, unfortunately, the same questions do get asked multiple times. However, it does give us kind of a redundancy of information versus missing things. So I suspect this type of information is being provided elsewhere to you. However, it will all funnel up to Steve, who's the design lead for social work within the project, and he would be pulling it all together to figure out how that Brandon and the other ambulatory social workers will be able to do their job across the clinics.
Okay, if it helps, just to add on to that, often we schedule Brandon to come at a follow-up visit for a patient, so they're kind of linked, and I think he just, keeps it on his calendar, and we have it, our secretary puts it in the comment section of the patient schedule.
Perfect. All of that, we will be talking through the pieces of that. So we'll see. It may remain me in this clinic, but I may become replaced by Steve Longstaff. But you'll see one of us in future meetings as we figure out the social work component of this clinic's work.
Thank you so much, Peter. Sorry.
No worries, my pleasure.
So we're going to go into the provider assessment and documentation.
Oh, sorry, one more interruption. I apologize.
Oh, yeah, go ahead, sorry.
Connie, is this relevant to talk about allied health in terms of skin prick testing by the allergy technologist?
I'm guessing Patricia's going to get to that one?
Yeah. That's the only other allied health.
I saved all my questions for the allergy pieces in the procedure treatment slide, if that's okay.
Yeah, gotcha.
Sounds good. So for the provider assessment documentation, provider sees patients as arrived and has been seen by nurse or allied health via personal or clinic schedules through ambulatory organizer, able to complete the medication reconciliation and prescriptions. They'll be able to enter internal lab or diagnostic orders that is automatically routed to a scheduling clerk's queue to be booked. They'll be able to document using Fessor and easily customizable templates. Consult notes can be distributed via Acceleris to various downstream systems. So little view here, again, provider will log on into PowerChart, review ambulatory organizer to review their schedule for the day. Or the week, and they'll be able to click into the patient's chart to review the outpatient chart. They'll be able to complete the medication history and MedRec as needed. And again, that's a conversation that you'll take back to your team regarding the documentation of the best possible medication history. Providers will be able to enter any orders or prescription required for that patient, and be able to document via dynamic doc of their assessment and intervention, all in PowerChart. So this is just some screenshot very quickly of BPMH and med reconciliation, which I kind of alluded earlier in my demo, which Ivana will go in a little bit more in detail. So this is the medication reconciliation piece. Again, a little bit more detail in the demo. Provider documentation. So very similar to the nursing piece, but for providers, their end page is called the outpatient chart, and their notes are, of course, labeled based on the service at the bottom with a little bit more types of notes. And currently, I believe we're working on creating something specific for the respiratory division group. Quick orders. So way more in depth, way more customized for the respiratory providers. And I know, Dr. Yang, you're working with our team again to edit and change this as needed. and reports. So something that did come up in the information gathering is that we noted that we are able to pull report for physician compensation billing report, and Ivana will be able to show you a little bit of that. Just gonna hand over the screen to Ivana.
Great. Thank you so much, Patricia. I'm just gonna hop on. I am having some connection issues today, so please feel free to let me know if you're not able to see my screen. Okay. Can I confirm that everyone can see my screen?
Yep.
Okay, great. So again, with the provider's day of clinic visit, they're going to log into the power chart. Again, your typical landing page will be the message center. And then you'll navigate over to ambulatory organizer, which Patricia's already kind of gone over. But essentially your day of clinic visit, your appointments will be available to you here. Again, you'd be able to select your own resource, so you can search your name here, and it will populate all of your booked appointments for that day. And so here currently you can see that it's seen by nurse. Again, if it's a virtual appointment that you're seeing the patient, it would be confirmed, and then you would click here and click arrive when you see the patient. But I'm going to enter this patient's chart here. And so my the position I am in is actually the pediatric respiratory position that you're currently building with the PET team. So you will see that at the bottom of your workflow end page, you have your respiratory ped clinic note and your free text note. So as Patricia mentioned, your end pages are comprised of different components, and essentially some of them are narrative in nature. Some of them are just to review information. You can access additional power forms. So under the forms component on the provider view, if you are doing COVID screening, there is the COVID pediatric patient screen. So if you're starting your day, you're wanting to review some of your information here, you can identify the chief complaint. You can also modify this if required. The provider position also has access to the team communication and the situational awareness. So you do have the ability to monitor and kind of communicate informally also with the rest of the team through this component. Again, if advanced care plan, if it's applicable or not, and if it's not, you always have the ability to customize those components and turn on and off what is most clinically relevant for you. So we did speak about having the ability to see where the patient has been with respect to their visits and which encounters have been created for this patient.
Can I ask a question? Is this outpatient chart by clinic encounter number, or like if some kids got 3 different clinic visits that day, how does that work?
Yeah, so that's a really great question. So when you are seeing your patient in your clinic, in the asthma clinic, you want to make sure that you're in the right location. So when you open up the chart, you want to make sure that it's the right location and the right encounter type. And so here, if you click on this encounter type, you will see that there's additional asthma clinics visits here for this patient. You have another outpatient, and then you have a pre-outpatient encounter. So you need to be mindful of which encounter you're doing your work in with respect to your documentation and your orders.
So I presume, like, if somebody, because usually what happens is a kid comes in for a pulmonary function test and then a clinic visit. Those, I think, are 2 separate encounter numbers. Is that right?
Yeah, and that's why we ask you to work off of this off of your calendar in Ambulatory Organizer, because all of your correct appointments are booked here. So you wouldn't really have to worry about if you're documenting on the right encounter and right location. It should be scheduled all properly. And then when you click here, it just has all the right encounter information, location, and all of that. So we try to make that less of a concern when you're accessing it through Ambulatory Organizer.
Okay.
But just to be mindful, yes, that there is additional encounters as people have a lot of appointments. So, yeah. So if we come down to documentation, so here is where you're going to have the ability to filter additionally notes. So for example, if for the day you're only really interested in seeing your own documentation or other provider documentation, you would select that filter. But say you are also interested in nursing and allied, you have the ability to filter. And so now you can see that the note that Patricia created is available to me here. I'm able to review it. You know, I really like also what she wrote. So I have the ability to tag that information. You do have the ability to filter like last 24 hours, 3 days. You can also group by encounter. So again, as your patients are moving across maybe clinic or inpatient space, you do have the ability to see those notes and they're grouped by encounter. So it's a little bit more helpful to put into context as to what you're reading about. Once we move into the history controls here, as Patricia mentioned, so nursing has the ability to enter this information, so does allied health, but as physicians as well, we have the ability to go in here and add any surgical information if you want. So if we had an epidemic, so I have the ability to enter that information. Say I want to do a family history, I have the ability to go in and do a quick family history. And then when navigating back to the chart, if you want to go back to your component, you can just click the little home button. And then if you refresh that information, you'll see that this epidectomy is available. And what's great about this component is as they move across live sites that are with CST Cerner or even within your own facility or across other clinics, the more information that's populated, it does cross encounters. Again, very similar components. They have immunizations for you to review. You have the ability to reconcile your allergies. You review that information. If there is any Care Connect information that you're looking for outside of the community, you do have additional links here to Care Connect and to the intranet for the drug dosage guidelines if required. So now that I've reviewed the chart, I've gathered my kind of collateral information, I do notice here that there is the best possible medication history that's been completed, and I can safely say that because there's a green check mark here. And I also see here that the salbutamol has been documented. So as a physician, I am reviewing this information, but additionally, I've had a conversation and maybe there's something else also that's been identified that the patient is taking. And so you do have the two ways of doing it. You do have the ability to click this add button and search for metformin or some other medication, or we do have what we call here the external prescription history. And so here you have the ability to import. Unfortunately, I don't have the patient, but what I have pulled up is the CST Cerner help. So essentially, once you click that med history button, you're going to come and click this import button, and your screen is going to look like this. So you have all of their medications that they've been, prescribed, say over a period of 6 months, 18 months. You would review that. You would click this little scroll button, and it will populate automatically here with the appropriate information. And then you would just click this document history tab. So it's really kind of a much quicker way to, instead of like searching and like typing in each medication, you do have the ability to just import that Pharmanet. If there's a 2 here or a 4 here, you expand that and it gives you more dosages or different times of the medication. So for example, maybe the hydromorphone is given, at night and also in the morning. So they would be separated out here and you would import them over.
Yeah.
Any questions there?
It's just, yeah. Brenda, what we'll do with that is for our next session, Connie and Ingrid will have a patient login that has sort of a Pharmanet profile attached to it. Just not all our patients in our bill domain have that. So you can actually see what that looks like in the steps.
So yeah, it will save you time instead of just searching it each medication one by one. Having that import function will definitely save you time. So as a physician and or nurse, you have the ability to do that piece. And then when we spoke earlier about the medication reconciliation piece, that is the ownership is with the providers. So you would come to this outpatient link here. They do have a blue, when it's indicated here with this blue circle and the exclamation, it just means that it's not complete. And the med history has to be complete before we can proceed over to the outpatient med rec. So once I click on the outpatient med rec, you'll see here that you've got this scroll, which indicates that this is a documented medication. Again, under the status bar, also it states that it's documented. It gives the name, the actual order sentence, and then we've got 3 columns here for you to decide on what you want to do. We have this continue button. That means that this is a medication you want your patient to continue at home. They perhaps already have a supply at home, or they have a refill at the pharmacy. So you can just click continue. Say this is something that you don't want to continue, you have the ability to select don't continue. Or if you want them to continue but they don't have a supply anymore at home and they need a prescription, you have the ability to click on this middle column, and you'll get this blue circle with the X, and that just means there's additional order entry fields that you need to complete and satisfy before you can submit this prescription. And so now here I have my 200 milligrams, it's inhalation, QID, and this one would be a mailer.
Yeah, just in the interest of time,
Yep.
this is actually
Yep.
stuff that we all have functionality. So I actually know how all this works if you wanted to skip ahead.
Sure. Okay, I'm just going to sign that. Okay.
Can I ask one question while you're on prescriptions? An issue that we have with Cerner right now is that when we print out a prescription, it doesn't have any clinic-specific information. It just has the generic hospital information. Is that going to change? Does anybody know?
I actually don't know the full detail. Like visually, I can't see right now in my head if they have the clinic name. So I'd have to loop back. Unless,
right now,
we have
it has the hospital name, but there is the thought of whether or not we would go more clinic specific in the future.
As in like with this go live or like future?
I'm not sure the timing on that. I'd have to check in with the ambulatory team. I'm not sure if anyone on this call knows.
That's okay. I just wanted to see if it was getting addressed. Thanks a lot.
No problem.
Yeah, once you have completed your reconciliation here, you can go on to address any of like the history of present illness. So you can use these components here with respect to starting to generate your note that will feed eventually into your PEDS clinic note here. So if I wanted to do test, say I wanted to do a physical exam, I'm going to do a short template. I can use auto text in here. I can use my front-end speech recognition microphone and dictate into these components here. So once I've completed all of that, I can open up my piece note here. And so you'll see you have a pre-populated template. The information that I entered into those components have nicely pulled into my template here. But I also see that I have a tag text here. And so this was that note that I pulled from Patricia's note. I took a little snippet from it and say I just wanted to add it here under functional history. So what it does is it will place it under the heading that you dragged it to, and it will also reference where you sourced that information from. And then at the bottom of your note, it will indicate that this was from the nurse educator assessment, who was the author, when it was completed, and what time. So you do have that functionality. So you have a templated version when you're completing your note. You also do have the ability to select this free text note here. And so essentially it's just a blank template, and you have the ability to go in and put in your auto text that we built out here for you as an example. And again, this will be reviewed when you are meeting up with the provider experience team to review the information. So we've just pulled in that auto text. You have the ability to review this information. If there's any other information to enter, you can just click and continue to either type or use your microphone.
Is
Any
this
questions there?
Yeah, as current cerner, where like if you have an underscore, you just F3 to all of the different open tabs, like open lines?
Let me double check here. I usually just use the mouse, so I'd have to play around. Fraser, do you know in terms of?
I'm not exactly sure. I know that the square brackets with the underscore are for the front end speech recognition, and I would assume they're also for tabbing between, but I'm not familiar myself.
Okay, thanks.
Yeah.
And do you guys know if there's like a standardized clinic header that's being used across the hospital, like a format, or we just have whatever we want?
Sorry, with respect to your notes, like
Yeah.
each note would have.
Yeah, see where it says asthma program, like does every single 90 clinics in this hospital just write whatever they want there, or is there some standard template you want us to use that's coming from the hospital?
I'm not aware of any standard template, but maybe someone else might be.
Yeah.
When the document gets distributed, the enterprise header and footer get added to the document.
But is the enterprise header footer just Children's Hospital, generic something, or is it specific to the clinic?
Yeah, no, it's not clinic specific.
Okay, so if we want clinic specific stuff, we have to actually build that into a clinic template?
Yes, correct.
Gotcha. Okay, thanks.
Yeah. And then you would sign and submit your note. You have the ability to, again, any free text templates that you're using, you'll just have to change the note, or you'll have like a generated list of just free text, which would be hard to kind of decipher on which type of clinic visit or what the visit was related to. So you have, the ability to enter here visit 3 or visit 4. You can change that. And then if you need this documented, distributed to anyone in particular, you have the ability to, again, search for the provider, add them, also have them as a default recipient. If the referring provider and the primary care physician is also entered in Cerner when the patient arrives during the registration process, that will be captured here, and those notes would be automatically distributed upon signing.
How do we know which notes are automatically distributed to primary care?
Yeah, so we have our clinic notes, our admission, discharge, believe our procedure, and operative notes. Those would be the 5 notes. And
Okay.
If I'm missing one, please, someone let me know.
And then under note type, are those going to be built out more specifically? Because I think an issue that we have with Cerner now is like it just says pediatrics clinic note, but it could be like one of the 90 clinics. Unless I know who the neurosurgeon is, I have no idea what clinic that note is coming from.
Yeah, so I believe the note types are standard across, and Fraser, correct me if I'm wrong. And then this is where you would indicate, if this is asthma, if it's endo, if it's psychiatry.
Right, but it's because it's free text, you can't really easily sort on a title. So if I want to see all of my asthma clinic letters, like I can't just sort by note type, right? I'm just trying to figure out how granular you guys are making the note type.
Fraser, I don't think we're going more granular than this.
Yeah, I'll have to double check. I'm not sure whether or not the type will be respirology pediatrics clinic or just pediatrics clinic. I'll loop back.
Yeah, out of curiosity, who's having those higher level discussions that sort of affect everybody who uses the system?
Well, the event set hierarchy, which kind of structures the document types, it was enterprise designed prior to Lionsgate go live.
And so what's their event set hierarchy for this? Just pediatrics clinic note?
That's not my area of specialty. I just know that it was designed enterprise wide, but it looks like Fraser's going to take that question away.
And out of curiosity, like in a place like, and I'm guessing this is the whole enterprise versus children's hospital. At Lionsgate, when there aren't so many pediatric clinics, it's probably not such a big deal. But here, when all we see are pediatric patients, that differentiator doesn't really help us at all. But I'm
totally understand. I know that children's was at the table when the event set hierarchy and document types were being reviewed. So
right. Okay, sounds good. Thanks.
And so yes, once we've signed and submitted our note, again, it would go through our distribution process. And my note, again, would, if I just refresh this component, be available, again, within the documents component for me to review and for any of the other clinicians that are working with this patient. So once we've completed the documentation, if there is any other orders that you want to place, in addition to that med reconciliation process that you went through, you do have the ability to add additional medications, labs, again, which is what we're designing with you with the provider experience team. So you have the ability to select any of those. But say if you did want to also have the nurse administer a Ventolin order, you do have the ability to do that. You would just indicate that this is for the outpatient here. I'm going to search Ventolin. And so say I want to just do 2 puffs once. It's going to capture all of the appropriate order entry fields. And you can see here that you would just click sign. And there's 2 things that can happen. So say you might be administering that drug or the nurse would be administering it. But for providers, their situation is a little bit different within the system, but they would just come to the MAR here. And so you can see here now that the Ventolin is populating the MAR. And if I wanted to administer it as a physician, I would click on it. It would give me the time and date that I'm administering it if I need to add any additional comments. And then I would just click this green button to sign that and complete it.
And is this for the purposes of just documentation, or is there some kind of like barcode that we're going to be getting Ventolin up into the clinic that's barcoded and things need to be scanned, et cetera, et cetera?
Yeah, for nurses, definitely, they will have the barcode scanning ability.
Yeah.
We don't have the ability to connect that barcode scan through this position. You would just be able to come to the MAR and click and make sure you're doing all your checks and your rights.
Gotcha. Okay, thanks.
Yeah. And I believe that completes my part of the presentation. I know we have a few minutes left here, so I will let Patricia.
Before you leave, can I just ask, so one of the issues now on the system, which is I think leading to this problem where we have all these unsigned notes, is that in our current Cerner system, there's no like list of like letters that I haven't finished or haven't signed off. In the new system, where does that show up?
Yeah, so you'll actually be able, if they started a note, you click the save button instead of the sign button. That message will be available for you, that document will be available to you in Message Center. And then you'll be able to go into your Documents tab within Message Center, open up your document, and then go ahead and complete it. And also you can access it through your Documents component. You'll have like an in progress a status, and you'd be able to click on it and then proceed. So there are two ways of accessing those saved notes.
Okay, thanks.
Yeah,
and then the other question I had is when we send people off for tests, and I know the labs and et cetera are actually coming back into this system instead of Care Connect, how do I get informed that a test result has come back?
So yes, we have within your Message Center, you'll have an alert kind of that indicates, it says in the results, you have results waiting for you to review. And then if it's something that's complete within the hospital, you'll have that available to you under results review. And then if you are receiving this, it's happened somewhere else in like Life Lab, that will also come in through our lab external function. And those would be also entered under results review in discrete data, and we have a separate tab for that.
And then is there a place to document in there like what I did with that result or that I've checked it?
Yep. So I'm sorry.
Yeah, no, go ahead.
Yep. So I'm Dr. Yang. So I can share my screen if that's okay.
Yep. Thank you, April. Yeah, go ahead.
And just let me know when you can see. Okay, can you guys see? Is that okay?
Yep.
Okay. All right. So to address a result, so when it comes into your Message Center, you will have the ability to review, and you can also sign as well. And so in this action pane, that's where you would do that. And if it's a result, say if it's a patient that you didn't follow or you have nothing to do with, you have the ability to refuse as well and send that result to another party to review and find out like what really happened, who actually saw this patient. Maybe it was Dr. Wong instead of Dr. Yang, and you would just address it that way. But yeah, so I guess the short answer is yes. So once the result comes in, you'll be able to address by signing or reviewing here in this action pane.
So for example, if I see a result and I want to say called family to whatever, so I click review, and then under comments, I type out called family aware of result or something, and then I sign it. And then where does that show up in the system in case somebody wants to know what I did with that lab result?
With that lab, I think it should show up in your documents. Hold on. So you can also create from results, like, and save it to the chart. So it should show up in documents. Anybody correct me if I'm wrong, but it should show up in your documents that you actually took action.
And out of curiosity, is that sort of, I'm just thinking like right now, our documents panel in our current Cerner is so cumbersome. I'm just imagining like all these doctors sending like, is that actually the workflow you guys recommend?
Yeah.
Got it. Okay.
Sorry. You mean like sending documents to each other?
Well, no, I'm just thinking like as physicians, we need to sort of like in the paper world, we sign something off or we write a message and then it goes into a chart. The sort of workflow you recommend for physicians to document that we've seen and actioned a lab result is this. I write a comment in this action pane and that generates a document in the document panel.
Yep.
Yeah, it'll go. Yeah.
Okay. Sounds good. I'll let you guys get to allergy testing because I know that's sort of the other big piece of
Yeah, thank you. I'm just going to present my screen back here. So where is it? We did have like 2 really quick questions for the provider follow-up items. The first thing, which I think we kind of heard of, is that assessment it could be made and then the patient sent to the ED. But our question was, do you do direct admissions or do the patient go through ED first, then into inpatient?
90% of the time they go probably through the ED. In asthma, we rarely do direct admissions.
Perfect. Thank you. And then a second follow-up question, knowing that Dr. Wong isn't here, but is Dr. Wong a resource for the asthma clinic or requires a separate appointment? Because I believe you mentioned, Dr. Yang, that they're in close proximity to your clinic and they just kind of come in and help out.
No, they're actually resources and providers. There's sort of like 4 physicians that work in asthma clinic. So 2 are within allergy, Dr. Wong and Dr. Hildebrand. And then Dr. Dell and myself are both physicians in the clinic. So I guess we're all resources.
All resources, okay. Do you think that Dr. Wong and Dr. Hildebrand will require a separate appointment? So for example, are they ever seeing the patient one-on-one just for like an allergy assessment or something like that?
Not within asthma clinic. So if they're seeing a patient in asthma clinic, they're booked an appointment in asthma clinic, but then they'll see all of their own patients in allergy clinic.
Okay, and then when they're seeing your patients in the asthma clinic, is it strict? That's a collaborative appointment with yourself and the nurses as well. Is that correct?
Not with me, but with the nurses.
With the nurses. Okay. Yeah. So then I'm just gonna move on and kind of jump towards our questions regarding.
Sorry, Patricia. Yeah. I just have a quick question. And I saw Ingrid put it in the chat. Connie, with regards to, because I can't remember, the nurse practitioner wasn't able to make it today.
Mina.
From Dr. Seaton, so from a pediatrician perspective, do they do anything different? Like, is their documentation the same? Like, okay, perfect. Thank you.
Mm-hmm.
So we understand that a skin prick test occurs in the clinic. What we kind of are unaware of, or we heard of, is the testing overseen by lab, where it's strictly done in the clinic by Dr. Wong's, the immunologist, or the allergy tech?
It's the allergy techs who do the test.
Okay.
And the allergy division supplies the materials for the test.
Okay. Are they ordered by the immunologist?
No, they're requested, I guess, by us in allergy clinic or in asthma clinic, usually at the time of the visit, or sometimes we'll know sort of the previous visit that we want to do it at the next visit. But there's no like order or specific requisition. We literally just knock on their door and ask them to do the test.
Okay, and the supplies and materials are provided by that service?
Yeah. And then I know Ingrid also does allergy testing. That's sort of not the typical workflow, though.
Okay, and Ingrid, if you complete the allergy testing, are you also are you interpreting the result?
No, the results are always interpreted by the physician.
Okay, so in terms of that workflow where you're doing the skin pricking test, is your documentation more of like a narrative note?
So there's a paper form that we're using currently that we sent you along with the forms that are currently used in the clinic, and so it identifies which skin prick testing has been done and what the measurement is.
Okay.
And so it's documented on that paper, and then it's currently scanned into the system with my signature on if I'm the one that's doing it or the allied health person that's doing it. And then in my nursing note, I will comment just a free text note that I completed it. Yeah.
Okay, sounds good. So for your documentation when you're completing it, it's the whatever type of irritants you pricked or used, and then the measurement of that, but the actual interpretation, whether it's a positive, negative, is for the immunologist. Is that correct?
For the physician, it's any of our physicians.
Any of your physicians. Okay, thank you.
Right, Connie? I think that's how it's done. Yeah.
Yeah.
Okay, thank you so much. And then I guess that was like our last question, but can you describe a little bit about that allergy technician's involvement in the clinic? This is kind of something that we just recently found out that an allergy tech is involved in your clinic. Would that allergy tech complete the same kind of workflow that you do, Ingrid, by doing the prick test, measuring, creating a note?
Yeah, so they are, we've been in a shared space, right? And because we share physicians as well as space and resources, they have been part of that specific test for our clinic.
Mm-hmm.
And so they use the same skin prick test document that they, record the results on with their initials, and then they deliver it to the practitioner, and the practitioner interprets it.
Okay.
So
And
they're not currently listed as a resource for a clinic, I guess you could say, Connie, right?
Yeah.
okay, so they're not technically scheduled to do the tests. It's more like a very casual, can you come and help kind of thing. That's to get them to do the skin prick test, or are they actually allocated some time in the clinic?
They're allocated time sort of through yeah, they are sort of allocated time, although it's not quite as precise as, say, like our nurses are like dedicated to our clinic. So if they're away, they're away. It's not like we have any control over that sort of thing.
Okay.
And so what they do is keep statistics on how often they're doing skin prick testing for the asthma clinic versus their specified FTE role in the allergy clinic, and then those, that's how we track their involvement.
Gotcha. Okay. So it's kind of a very whenever they're available type of situation.
But it's usually most of our clinics that they're available.
Okay, gotcha. And are they booked into your clinic? Just to make sure. Sorry if this is redundant. They're as a resource? No, they're not. Sorry, can you repeat?
No, not a resource.
Okay, not a resource. Okay. All right, thank you. So we'll come back a little bit more with more clarity regarding the skin prick and documentation and the allergy technician's position and documentation as well later on, potentially in the second design session. So we are over time. We do have our second design session scheduled for, sorry, I just want to go down here, get the dates, for April 7th to go over the rest of our slides, which will include the medication administration. I think we just went through procedure and treatment, but maybe clarify a little bit more to loop back about the allergy testing and specimen collection workflow, forms, discussion, virtual health, in between clinic visit, and a little bit more of a detailed overview of Message Center for the providers. So we are inviting you for April 7th for that second design session to cover those content that we didn't get to today. And then validation session will be booked for the April 21st, where we were going to come back with everything hopefully built out in the system. So that's your locations, medical services, to go through the actual clinic visit workflow for how the patient's trajectory happens in your clinic, whether that's in the clinic or virtually, from end to end, from referral to departure. Does that sound good?
Yeah, Patricia, can you just send us the slides?
Oh, sure. Do you want me to send you the slide? Yeah.
Yeah, I think that would be helpful. And I know I'm hearing this from a lot of the practitioners in all of the clinics is that they don't have time to attend all these sessions. What is the critical session for one of the nurses to be at? Is it validation or is it design?
So the next one for nursing would definitely be, well, for medication administration, that might be something new for nursing, and also specimen collection. They might, if that's something you'd like to review, that would be discussed in the design session number 2. But validation would be the most important, because we would need consensus that that whatever we're presenting to you in terms of your future state workflow is something you agree with and it's going to fit your clinic needs.
Yeah, Connie, I know there's a lot of sessions, especially for all your clinics. Like, ideally, we identify sort of critical roles in each session, because we don't want to get to April 21st and have Ingrid and her team say, this is nothing that we do.
But I think just realistically looking at what you guys have presented, nothing is really changing because there's a bunch of stuff that you guys can't build out into the system. And I totally understand that's just the scope of the CST. But like, I know Ingrid and Lindsay are doing this in between clinic visits and they're sort of super busy. And so I just want to make sure we're using their time as wisely as we can.
And also, I know we tend to base the availability, of course, off of like Connie or David's availability. But if there's like certain times, like if, in future where, we do not want to book these days on the days you have clinic. If there is that flexibility from a design team perspective, it's hard when these things are set up, but in future we are able to sort of work around that. It just becomes difficult when